Um, so honestly, I'm like still a little bit in shock because there were a lot of surprises when I got here today, like mascots from Fenway, like our name on the Jumbotron, like this incredible space, like these trophies. I mean, I'm like got chills. Earicles is so grateful to Fenway. They've honestly been the most amazing partner. They've been so generous to Earicles. So like I'm trying to get over my excitement and we're gonna go on to talk about ears. Please let me just make a few special thank yous and we'll get started here. Thank you to Earicles. Earicles is my nonprofit. We're dedicated to helping these little ones thrive through education, advocacy, research, and we give free surgeries away for kids that are qualified. Also, my sponsors, you guys are awesome. We have all these 4 vendor tables. I saw a bunch of people at them. They have gifts and toys. So they've been wonderful partners. Thank you guys, everybody. Okay, dude, like, look, these are our kids on our patient panel. Everybody volunteered to be here. We have to turn people away from being on our patient panel because we get more kids than we can actually do. So it's like a first come, first served basis. You're going to meet all these amazing kids and thank you so much to their families. We're so grateful for their special families. Okay, it does take a village. I will tell you, Tiffany puts more time and energy into this conference than you guys could ever imagine. So we have to just give a round of applause to Tiffany. And all the staff is right behind her, helping her with all these things. And Rudy's here today. Yay, Rudy. Okay, we have. You feel like you wrote? Yeah, feel okay. So that is our 1-year-old Buford, the newest member of our team. He comes every Tuesday to clinic. If you come to California, you will meet him for sure. And our patients really love him. But if you're allergic to dogs, we get rid of him. I mean, not really get rid of him, but move him to Rudy's office. My family, I have to give my thanks to because they have been so supportive of me from really literally day one. My husband, John, and my daughter, Casey, are both here today. Please go. Oh, Casey's there. John is in the back. They really have been a constant source of support. So thank you guys. Take a picture of this slide really quick, one person in each family, because if you end up having questions, this is the number we're going to have you text. It's Tiffany's cell phone. We'll filter out like duplicates and we'll do our best to do that. And if maybe your neighbor took the picture if you didn't have time. Okay, we're going to start our talk right now. So really, we're going to go through kind of my evolution in ear reconstruction. I have to swallow here because this marks my 20th year making ears, which is a lot, but I have to tell you, many people have heard me say I am the happiest and luckiest doctor that there is in the world because I love, every part of my practice and I just find it so incredibly rewarding. I couldn't imagine doing anything else. One of the things that I find fascinating though is even after 20 years, I'm still learning new things and I'm still developing new techniques. And that's what makes me able to sort of commit myself to one single surgery actually for my whole career. So it wasn't planned that I would end up at this place making ears, and it did occur by serendipity. So it was more like a chance occurrence that ended up being my perfect pathway. And in order to understand maybe how I got here, it'll start with in college where I fell in love with studying architecture and I went on to get my degree in architecture because I loved how artistic and creative using design, just every part of it made me excited. But when I got ready to graduate, my husband said in a conversation, I was saying, I'm not sure this is what I want to do for the rest of my life. And he said, I always knew you should have gone to medical school. So he actually figured out a way for me to go back to school after college graduation. And I ended up in medical school. And when I got about halfway through medical school, I started missing the creativity of architecture. And so I saw my first ear reconstruction at Stanford, and I'm like, I have to end up in plastic surgery. So I went on to do that. I learned about ear reconstruction, and the rest is history. That's what I've dedicated my career to. So here's a patient of mine, but she's not a patient with microtia. But you look at her ears, they look normal, they look symmetric. So you really don't think twice about looking at her ears, and we just look at her beautiful face. But this isn't the way she came to me when I first met her. This is the way she came, and she was very concerned about her appearance and the fact that her ears stuck out from when her hair was down. And so in one relatively simple operation, we can do this outpatient surgery, not very painful, and it really changes her whole face. So to me, really truthfully, an ideal ear is actually one that no one ever notices, because if you're just born with two symmetric ears, nobody ever pays any attention. So although microtia is obviously very different, our eyes are used to looking at symmetry. And when we see asymmetry, or one and one missing, we're sort of drawn to that. So my goal as a surgeon is to create an ear that looks so symmetric to the other side that all you see is this gorgeous face being silly. So now let's talk about microtia. There is a wide spectrum, and just on our conference alone, I think we have a lot of this wide spectrum present, and it goes from a partial ear that's a little bit small to no ear at all. And as far as surgery goes, that whole spectrum takes you from easiest to hardest. These are the grades of microtia that I think a lot of people have heard doctors describe, and about 80% of patients will have grade 3 microtia. The hardest is grade 4, what we refer to as anotia. But sometimes it's more than just a little ear. These kids can also have a condition called hemifacial microsomia, where a part of the face, the jaw, even sometimes the nose and the eye can be smaller. And again, there's a range from mild to moderate to severe, and similarly challenging to very challenging. Okay, this is a slide that's in every talk in some form or another, and I'm amazed at how universal this concept of parental guilt is. And so it's worth it to me to spend 1 minute talking about there is nothing that a mother did in pregnancy that led to this. This is just something that happens. We honestly do not know why. It is so natural, and I get it. I get it. I'm a mom that we still feel this tremendous sense of guilt. But I'm telling you, today's the day you're going to put all that away, because all that really matters is you have this beautiful child, and your job is now just educating yourself. Maybe you treat, maybe you don't, but you're just going to educate on the options. So since the 1990s, we really had these two options: rib cartilage and porous implants, sometimes called MedPOR, sometimes called SUPOR. But it always kind of bothered me that when you look at the complexity of a natural ear, these really don't measure up. They don't have that delicacy. And when you're in medicine and you look at, or surgery, I should say, and you look at the cartilage that creates this, this is what you study to learn how complex the ear is. All these Latin terms for every little nook and cranny of an ear. So in order to create this, it's quite a challenge. And in fact, creating an ear is universally accepted as one of the most challenging operations performed in all of plastic surgery. I think I love it for that, because I never feel like I'm there. I don't know that I'll ever get there to create a perfect ear, but the challenge is what I really live for. So making ears, in my belief, absolutely requires artistry and creativity. It's technically a very challenging surgery, but it's a combination of these things. So some or even many surgeons believe that you can't take your ear off and compare it to the other side. So you don't ever need to do like a mirror image ear. And I don't understand that at all. I think the way a sculptor thinks, you're going to this long, complex surgery, you want to make something that looks as close as possible to this other side. So that's why I created this operation. We call it a 3D Lewin ear. Our patients actually named it that, not me, but I appreciate it. And so today I'm going to tell you a little bit of how we get there, or how I got there. 2005, I finished fellowship until 2017, relatively recently. We used, pretty much everybody in the world that did this surgery used a porous polyethylene rim and a base, what we call a two-piece implant. And you welded it together in the operating room and you create this implant made out of either Medpor or Supor, but the material is the same. So this is what that implant looked like. And to give you an example, this is one of my patients who had a very classic grade 3 microtia, a very mild hemifacial microsomia. And we did that operation for her. And here she is after 2 surgeries. And you can see her before and after. And from the lateral view, this was a Medpor patient from 2012. And she visited me 12 years later. She came to the office and here she is, and her ear, I thought, stood up quite well. Here she is in a oblique view. But I love this quote by Jay Mazel. If you're not your own severest critic, you are your own worst enemy. So I am going to be critical. I remember loving this ear when I made it and I saw her and I was so excited. But I am going to be critical because if you look at the rims, they're not the same. It's like an extruded computerized rim, the one that we used to use from Medpor. So it looks very regular, whereas the natural rim isn't. And the anti-helix was always the same, whereas everybody's is different. And then this is where you can see a huge difference. We just weren't able to create that complex shape. The earlobes, always a challenge, still a challenge actually, but really also the tragus. Tragus is really important. It hides your canal, and we really struggled to make a tragus out of cartilage back in the day. So I felt this two-piece implant had too many limitations, and I was frustrated because I kept waiting and waiting for there to be a better option, and there was no better option. So I decided this is when I would just develop my own better option. So my first challenge was, how do we completely redesign this and make it a one-piece ear? So this is the first patient, such a trooper. Let me do my first one-piece ear, he and his family. And this is what that very first generation implant looked like. And this is what he looked like after he healed. And if you compare it to a natural ear, this is the first generation implant on this side. I felt like I was able to get a more realistic tragus, that little triangular shape that hides the canal, a more realistic bowl. And then we could create kind of a simulated canal by creating a shadow behind the tragus. And then we could also get better strength to the implant because it was a one piece, and even a better, more realistic rib. However, everybody's ears are as different as their eyes and their noses. I mean, our ears do have a lot of personality and character, but as I said in the beginning, we don't look at all those differences because we don't really notice ears when they're symmetric. But I wanted to be able to match these because you wouldn't want a one-size-fits-all for this. So the challenge was, how do we mimic this uniqueness of individual anatomy? Okay, this was the game changer year. I was able to develop this technique that I use today, so for the last 6 years. And it came because we had this awesome Artec 3D Space Spider scanner, which is probably still the best one out there. And it's a painless, quick way. Many people are going to get scans done by Rudy later today and tomorrow. And we'll show you how we use that. It gives you an incredible, beautiful resolution and accuracy. That's like basically pinpoint. But in the software, I can grow this up to an adult size. I can modify the anatomy, which we have to do not infrequently. And then I can specify the base, design it to my patient's hemifacial microsomia. So Supor has been a wonderful partner, and they create these patient-specific implants. And we were the first to develop this, and now Supor is growing and getting more surgeons interested in this technique, which is super exciting for me and for them. And so if you look at this ear from all angles, this is one of our first 3D ear implants, and you can see you can mimic the anatomy so beautifully. So I was the first surgeon to perform this technique. And to me, this implant solves all of the design flaws of the old two-piece implant. It allows us to get that mirror image, and it's a much stronger, more stable implant. So our first case was in 2018. So if this was taking place next week, I would have said, I've done more than 650 3D Lewin ears today, but we meticulously count, and I have done 649 ears to date until next week. This is a point that is important to me because I constantly reevaluate, I constantly change. Ask Rudy in the OR, I'm like, wait, doc, that's new. And it's because we're not there yet, and you have to keep pushing the envelope. So I'm on my third generation of big design changes, and I have done hundreds of minute design changes along the way over years of time. And to me, the results are much more realistic and symmetric. And this is kind of exciting for me. When I first started, everybody's like, you don't need a 3D ear and you don't need a one-piece implant. And doctors were hesitant to embrace this concept. But now that we are 6 years into this, we post pictures of our kids and everything. I believe many surgeons now see this as the technique of the future. So I was thinking about this talk and I realized like I've made kind of a subconscious or unconscious change in my philosophy about ears. And it's because like, you're learning, you believe what you're taught, but ever since my initial teaching when I was a fellow, I've made this slow change. And I've realized in hindsight, though I didn't think it at the time, that I was sort of taught a cookie cutter approach. And by that, every patient got the same implant. We were told to tell every patient, do this as young as possible. And that kind of made sense, like psychological reasons, I can see it. But, everybody should do surgery at 3. And we were told every patient that's ineligible for it should get a surgical canal. It was like everybody. So that wasn't much that we thought too hard about. It makes sense, like you want to hear. And that every patient got the same flap. But what has happened over time is that is not the way I've practiced this at all. It has really boiled down to each and every individual patient. Like you'll see, I spend a lot of time on all of your IPA sheets that have all your information in my head, trying to think of all my questions for you guys. I mean, you get questions for me too, but I'm trying to think of that because it's really individualized care. So each patient basically, in my opinion, should get their own unique implant if they already have one non-Microtia ear. And for me, because this implant's so complex, you need a bigger flap. We start the surgery at age 5, but I don't say that that's the ideal age for surgery anymore because some kids do better at 10, some do better at 15, some do anywhere in the middle. I've done operations on a 50-year-old. It's so many things. It's not like just an ear and everybody gets the same treatment. I really had quite a pendulum swing on surgical canals. And if you follow me, you might be aware of this. And it doesn't come from me, by the way, you guys. It comes from patients that got surgical canals. I heard regret from parents that they did this. And I had an argument with my husband. I remember one day by our fireplace where I'm like, there's so many complications and problems, infections, stenosis, removal of ears, all these things. And he's like, why don't you tell parents that? And I'm like, look, it's their decision. It's their job to do the research. And he said, if you were taking your kid to a doctor, wouldn't you want to hear that? Because I hear what these patients are not going to tell their Atresia surgeon, who is trying their best to do their best. And I get that they are. But like what has happened over years is I've just heard the other side of the story that you don't necessarily get when you walk into the Atresia repair office, because they may not even know, but they can be problematic. The hearing results decline over time often, and you cannot match a bone anchored implant. So we have Cochlear and Oticon here that have the Ossia and the Sentio. I want you to talk and learn all about this. Because Sentio is new, I have not had the opportunity to do this implant yet, but I plan to, and I let my parents decide what they want. So you guys talk to these guys and figure out what you want. And finally, in terms of unique care, of course, these kids are very unique on the outside, but they're very different anatomy, not just on the outside, but they're unique on the inside as people, of course, but to me as a surgeon, they are unique on the inside because I'm going to find a surprise or a difference or something that is going to be different between these two patients, one of whom is on our patient panel. Okay, another one on our patient panel. This kind of just happened, but it's really cool. We're going to give the story of Wesley here. You may remember him as the young man up here telling you that he made a 3D printed widget for every single one of you kids in here, which is amazing. So thank you, Wesley. They came from very far away, and on September 18th, 2020, he had his big ear day. And I'm going to walk you through how that day goes for generally for patients. 5 a.m. family arrives at Cove. Here's Wes. Are you super drunk right now? Oh my God. Adorable. That's what happens with Versed. I'm just going to tell you that's like the baby margarita. It's a little confused, but happy nonetheless. Everybody gets a selfie because that's my tradition. 5:45, I go in before the patient and I start carving the implant. And then 6 a.m. off to the OR to fall asleep, no needles, no pokes.
Yeah, feeling pretty good, huh?
Just a little bit of breathing through a mask. Once you're asleep, we start our planning of the ear and we look at anatomy, figure out where should the ear go, and then we look at all of the specific markings that I'm going to do for surgery. So this is the way the incision looks. I feel for these arteries. We design where the flap is based on those arteries. So it's not always like this. Sometimes it's a little more from the backward. It just depends on each child. And this is what the flap size is. It's quite large. So if you are at all not wanting to see something red that is inside your body, it's just normally red because blood flows through your body. You can close your eyes for this part, the next few sides. It looks just like a fruit roll up, you guys. It's not really that scary. Nobody's allowed to eat it or anything, but when you put light through it, you can see arteries and veins in the flap. And I'll tell you, this is the most important part of the surgery. The way you dissect this flap is 100% what leads to a successful ear. Now, I don't do this as much anymore, but there was a reason in Wes that we needed to borrow from skin from the back of his opposite ear. So the markings are actually on the back of the ear, but that's the shape that it is. And you can see the incision there. And in his case, we needed to use it to make the front the proper color. So he had enough skin of the right color. So the abdomen skin we use for the back of the new ear, and the skin from the two ears we use for the front of the new ear. And then here's one more flap picture you're going to see soon, so close your eyes. But this is actually the moment that we all talk about in surgery. We call it the suck down because we put the flap over the implant and we put it on suction and voila, an ear is born. So that's kind of a celebratory moment in the OR for us. And here you can see the area where we took that huge flap from does not have any scars in the scalp. About 2006, I developed a way to take this flap out without any scars. Then you can see our incision is actually mostly in the back of the ear, but we, of course, always make sure that we save the little ear. In girls, you'll see on our patient panel, it gets pierced, and in boys, it will become symmetric to the other side. So this is our OR. My architecture background was fun because I got to design my office and my OR. And what I loved most about this space is I got special permission for that white covering so I could appreciate the shadows there. But we often get the question, do you take any breaks? And yeah, around 12 o'clock, I get a little bit of a break for a snack and a potty break, of course. And we appreciate the trees. So from 12:20 on, this is when we put everything together. This is very variable. It could be 2 hours, it could be 3 hours. We don't really know, but here's Wes at the end of surgery and everything looks great. There's his 2 ear grafts and his earlobe. And 1 week later, here he is looking great. This is very typical, bruising and, you know, red, puffy, pink. It's crazy looking. And all this seemed normal to me, but the story doesn't end there. So at 2 weeks, I start noticing he has some little sores and everything. And I'm like, oh, not great, but we're gonna give you a treatment and we'll get that cleaned up. And 3 of them cleaned up, but 1 didn't. So he's still got this sore. And then even though mom was diligent with the dressing changes, by 5 weeks, he has what we call an exposure, and you can see the implant coming through. So does this mean the body rejected the implant? No. Bodies cannot reject something that's not living. They can reject living tissue like a kidney transplant or a liver transplant, but they can't reject the implant. So what you think of as rejection, this hole, it's actually not due to the implant, but it's a tissue flap problem. And that's why I told you the most important part is not the implant. It's how you dissect this flap. And having dissected thousands of flaps, they have their own uniqueness to them. They are not all the same. But if you can do that flap perfectly, then your ear reconstruction will be durable and stable. So, of course, my proudest accomplishment is my son, Jeff, and my daughter, Casey. But if you asked me my proudest professional accomplishment, it would be meticulously training myself to solve complications like Wesley had, this exposure. It's hard to get a beautiful ear when you have a problem come up. I'm going to tell you, you can see I chose a patient with a complication for a reason. Like, I want you guys to understand these are hard. They're hard for everybody. And they sometimes have bumps in the road. But if you can elegantly solve those bumps, it's very rewarding. So we took Wesley back to surgery and it looks dramatic, but we had to remove his implant. So that's his, 6-week-old ear that we just made. We took the implant out, but that's his body's tissue. It's amazing. For the rest of his life, that tissue is essentially reusable. So we put a new implant in and I did some magic in the back and there he is. And I preach this to every parent that walks in the door. Patience is a virtue. It just takes so long for these to heal. So 9 months later, mom sends me these pictures. And it's honestly very hard to see where that exposure was or those scars, because if you give it enough time, trust, it will get there. So here's Wesley before surgery, and you can see his left ear there is a little bit on the prominent side. So we actually have a cool way to deal with that. And I can do a scan where in the implant design, I do what's called a virtual otoplasty, where with software and even with some tricks that some of you may get tomorrow, we can put the ear back and scan the ear back or design it. So we were able to do that for him. And there you can see his little otoplasty. And here he is before and after surgery, shows that. And here's his other views. When can we get back to sports? 6 weeks. Back to your normal life. You do have to be careful for those first 6 weeks. So I had a little post on our private group and everybody chimed in with pictures. So I put everybody in there. But what I really want you to see, 4 people, that we put in here sent pictures with their kids in helmets. So you think, you can't be in sports and you can't wear helmets, but you really can. And everybody, we have so many athletes. Wrestling, MMA, and boxing, not allowed. Don't even ask. Like, if that's what you're doing, don't get in here. It's just not worth it. We're going to talk about healing now after surgery. So before surgery, I don't know if you can see, it's hard to see on the wall, but cool haircut, right? Just remember that for later. So here he is right at the end of surgery in the operating room. And this is a different job, by the way, but here's 1 week out. You can see things look a little funky towards the bottom there. 1 month, scars are thickened. They're going to get thicker before they get thin. 2 months, things are starting to change. And actually by 3.5 months, it really starts to look like an ear, like a real ear. But there's a lot more healing that has to be done, like a 1 to 2 years wait till we get finished. So I'm going to walk you through 5 months, 7 months, 12 months. And then a mom sent me pictures at 2 years. And okay, that's why I said, is that not the coolest haircut ever? So the skin quality and the scars is what continues to improve over time, well beyond 1 to 2 years. So I just want to make one little point to parents out there that it doesn't really matter what the ear looks like at the beginning. So in surgery, kind of a typical picture, 1 week later, parents are probably freaking out that they made the wrong decision. And 4 months later, this is what this same exact patient looked like. So that's the patience is a virtue part of the talk. I do want to show you some before and afters, of course, and I'm going to first talk about my biggest pet peeve. I think, I spend time on these pet peeves because if I was in the audience sitting where you were, I would want to know this. It's not really talked about, but I'm frustrated when surgeons are not transparent with their results. We are all taught the same photographic standards, and I know all plastic surgeons take pictures of every ear from every angle. I mean, you talk to any patient when they go to the doctor, oh yeah, they take every angle. However, the standard are frontal views, oblique, lateral, and what we call worm's eye for ears. These are the same that a cosmetic surgeon takes. Any cosmetic surgery's website has all of these views. It is absolute standard of care because how can you choose a surgeon if you're not seeing these results from every angle? So I did an experiment, you guys, this was a few months ago for a different talk, but I Googled Microtia reconstruction before and after. I took the top 10 websites that came up on that, and I recorded the number of patients in their photo galleries. And here you can see for most of them, they had a good number of patients. But then I counted the number of pictures of the opposite ear, their non-microtia ear. Besides my own website, only my alma mater, Stanford, kudos to them, was transparent with these results. There's no reason for that I can come up with. Why would you not put the same thing that every other plastic surgeon has on their website? If you're only looking at a before and after one view, it looks great, but you can't tell if it's too high, too low, not projecting, too big, too small, etc. So I'm just going to mention the elephant in the room. The reason I believe you don't see these is because they don't compare favorably and they don't want you to see them. Well, I have kids on my website that I may not love that I got everything perfectly, but it's my work and it's for you to evaluate and you should be able to see all of this. So I just take a few minutes to say, you have to be a big advocate for your kid and you just have to demand more. You know what I mean? So we'll get to some results. I'll kind of go through these sort of quickly. Eventually, I will get 3D ears on my website, but unfortunately my website's 5 years old, so there's not a whole lot on there. But in social media, you can see these results. So here's a classic young 5-year-old girl with a very, very classic microtia. And here she is after one surgery. And for these young kids, you can see the ear is made a little bit bigger. Even that is not the same for all kids. I've come to learn over time, she's a petite girl. She is never going to have a really big ear. So you kind of even have to size the ears based on their head and all of them, their whole little person. So here she is after her one surgery. And here she is to show that you can get matching projection and nice symmetry. I'm going to kind of give an example of one of each kind of type of sort of some of the patients I saw that were coming to this conference today. So here's a picture of a patient who had a combined 3D ear and bone anchored hearing device. So here he is before and 8 months after one surgery. And he wanted to keep his projecting ear, so we matched it for him. There you can see the oblique view before and after, and then comparison views. And in these pictures, I didn't have him wearing his device. He got an osseous. I've done hundreds of osseous because it's been around since 2020, and I plan to do many Sentio as soon as they are available. It is up to parents to decide which device. So that would be where it sits. Real quickly, it's kind of the same for these bone anchored magnetic devices, but the basic technique is just you drill a tiny little hole, very small, you put a little titanium implant in there. This is the skull in a very cartoony way. And then this was the device that we used in this child. And the transducer is the brain, I think of it, magnet at the top. And there's this one little screw is the way this particular system affixes to the skull to get bone conduction. So that gets screwed into place there, cover with soft tissue. And then the processor is the only thing that's actually on the outside. So you can see it affixes with a magnet. So this is another one of our patient panelists, Miss Simona. So the osseous can be placed either at the same time as the 3D ear or after the 3D ear. But we do not place it at the same time. Excuse me, we do not place it before the ear surgery. And the reason is if you look where the ear goes and you look where the flap is, when you put the device into place, you can see it's interrupting the flap. So our preference is to do it after. And if for some reason I can't do it at that time or a patient decides later, if you come to me for this, I use in order to place these, the exact same scar that we had before. So no scars in the hair. I know that traditionally that's not the way that people are taught to place these, and they do make a different short incision in the hair. But if you wear your hair very short, that would be visible. So I prefer this approach. Then there's bilateral patients with microtia, and this little one got lucky in a sense because we just did one surgery on each side and we were able to get an ear and an osseous on each side. So before and after, you can see she wears her two osseous at the same time. She's a cutie pie. Then I want to talk about what I would call a typical revision surgery. So I'm going to use the baseball analogy. Many of you might have heard. I'm pretty good at triples in one shot. It is pretty hard to get a home run all the way around the bases with only one try at the ear. So sometimes you need a little help to get around the bases. So this is an example of a girl that her earlobe, like anatomy and positioning and structure, it was a little bit atypical or a little bit hard for me to get, perfect in one surgery. So here she is after her one surgery, but if you look up close, you can see that earlobe, it's kind of folded on itself. It's not sitting appropriately. It creates an unusual shadow and earring situation for her. So she was older, super mature. So we were able to do this in 30 minutes with local anesthesia. For younger kids or kids that may not want that or that are more involved for the second stage, we would do it under general anesthesia. Here she is after her little revision, and her earrings are a little more symmetric. So atypical revision is when I was still learning about 3D ears. So earlier in my 2020, 2021-ish age, we had this beautiful little girl, and I told the parents I thought she would be just one surgery. I can't always predict that. I always say expect that there could be a reason for a second. But if you analyze her result, you can see she's actually over projecting. So I overcompensated for her, and her ear fell a little bit lower than the other side. So for her, we had to do a revisional surgery that wasn't totally planned, but we're able to get her much more symmetric. And here she is after her second surgery, and before and after. And here she is. Mom sent me pictures 4 years post-op, so really cool. I love when you guys send me post-op pictures. This would be more of a planned two-stage surgery. So sometimes I'll have a consultation with you guys and I'll be like, we should expect a second surgery, and we even book both surgeries at the same time. So this gorgeous little one has hemifacial microsomia, which I would call moderate. So if you look at the base of her non-microtia ear, it looks very straight and stable. And you look where her ear needs to go, and you can see that there's like essentially an indentation in that bone. And it's the bone where the ear implant sits that tells me how challenging the surgery is going to be. But for her, we can predict that it's going to fall down. So here it did. Here she is. She's coming back for her second stage, but we were able to take a video of her so you can see the ear actually looks quite nice, but it did predictably fall down into that little valley. And so what we do the second surgery, you now have scar tissue, and I'm able to use sutures in a way that I can't at the first surgery. And so that allows me to do more stable ear reconstruction. I can't always get a hemifacial like perfect, but this is her after 2 surgeries. So that would be sort of one that we knew we were going to come back to. Okay, there's some patients that I saw that have this, and it's not common at all, but I call it a low grade 2 microtia, where you have a canal and an earlobe usually, but they're sitting much lower than the opposite ear. It is harder than it looks. I tell these families 2 surgeries, same reason as before. This is one patient that we were able to like make it work with 1 surgery. But here you can see his low remnant, and if you lift up the flap, there's a complete large ear canal. You can't close those, you cannot move those. You can't build an ear. I mean, I've seen people try and it's awful, but you can't build an ear around that. It's way, way too low, and you can never look as proportional as you want. So what do? I basically invented a procedure for this. I don't know that I've seen it anywhere, but it pretty much works as far as I can see. It's a little out of the box. So I didn't remove the canal. It's there, but I try to hide it. I try to hide it behind the earlobe. So here he is after one surgery, and you can see his comparison views to his opposite ear. And there's a lateral view, and you get a sense of a shadow here. And even from behind, you get a sense of a shadow there, but you have to look from below up in order to see there is his canal. It's sort of very hidden. You need to do this so you can clean it. You've got to have access. You can't like go to an ENT and close it. That's not the way it works. It has to be preserved, but if you can hide it and create a symmetric ear, that's our goal. It's challenging, I will say, sweating about it. But anyways, right microtia after canal surgery, or what doctors refer to often as atresia repair. So this is a little kid, he had his atresia repair surgery. You can see the little hole right there where the scar is. And here he is after one surgery. He's very slightly lower. We cannot place the ear where we want to when you have a canal. Obviously, we have to alter the implant, alter the flap, and we have to, put it where the canal is. So if the canal is a little lower than the other side, the ear will be a little lower. But I thought in his case, very subtle. And here he is after one surgery, 3.5 years post-op. Here he is. So he's maintained his positioning, which I'm super happy about. There you can see. So I do want to spend a little bit of time talking about atresia repair because of that sort of change in philosophy informed by families. 15 years ago, I said all patients that were good candidates should have this surgery. And realistically, ENTs will tell you only half of these kids are really good candidates. And that depends on their skills. So I really looked at the literature because what I wanted to find was long-term hearing results that are sustained. And we looked at all these references. Obviously, I just have this so you know that I'm not making these numbers up. This came from actual data. Okay, this is a hard slide. I'm going to warn you, it's long and hard. But again, I guess I put it there because if I were you, it's worth the 1 minute we're going to take to try to go through this and understand an audiogram and what hearing means to your kids. And so I love that the audiologists do this and they put things at different decibels. So a whisper, is at 10 decibels. The degree of hearing loss is this column on your left, and the frequency is at the top. And what you want to know is normal hearing is 0 to 25 decibels. So if we mark that with a line, that's where we want to get to for our microtia kids. You and I might be at 10, so we can hear kind of everything below. But if you just hit the bottom of normal, you still hear a lot of these letters, okay? The letters for speech. So that's really critical to audiologists, you guys. They call this the speech banana because this is at different frequencies where words or letters fall for us to be able to hear them. So this speech banana is our goal. We'd like to be as high up on that so we can understand those sounds. Your kids with oral atresia sit almost all in this moderate to severe range. Some a little worse, some a little better, but this is the average. So they can hear a dog bark and a vacuum cleaner, but and anything below. But they're missing all of the speech banana on that side. So you need to increase to get to normal 30 to 45 dB. It's a huge, huge amount. Atresia repair, this is based on those 9 articles. It gets you in the early results an exciting 25 to 34 dB. And if it lasted, this would be amazing because you're in a mild hearing loss. And for some kids, no doubt they get there, but based on published results, the actual published results, and well, I'm not gonna make another comment on the ones that get published. The late results are only 12 to 26 dB. And that's why it's a frustration to go through that much surgery and that high risk and end up just one step below, or excuse me, one step above. However, on published results of Ossia, and I'm sure when the Sentio gets published results when they've been around more, we are going to see that these bone-anchored hearing devices can get you 35 to 41 dB in the normal range. So if we really want to help our kids hear, if that is our goal, I think this is, you know, a wonderful solution. I am gonna, I talked to an ENT who's very familiar with all this, and I made sure, I'm like, I don't want to say anything wrong, so tell me, are these all correct? And he's like, yes, yes, yes. So I'm gonna tell you, even the best surgeon in the world, you cannot predict for any kid the hearing improvement. I know you're told 80%, 70%, but in reality, that's not exactly the way it works. The long-term data has not proven that the hearing gains you get early on will last over time. Many bilateral kids, I mean, most bilateral kids, I think even the Atresia repair surgeons say will need a surgically implanted bone conduction device to get to normal hearing. Most of the world has truly abandoned this surgery. If you poll people in your local institutions, very few people do this anymore. I've had 4 patients lose their ear implant from complications of the canal. Now, I've done thousands, so 4 is a very small number. But if you are one of those 4, it's 100% for you. So it just needs to be something you're aware of. I have had many patients have to get their canals closed. I never hear Atresia surgeons really talking about this, but just in this very room is a mother whose son had bilateral canals created by the maybe most experienced person in the world, and both of them have been closed. And sadly, one of them, well, I'll get to it. A lot of patients return to baseline, but this patient's hearing, bilateral patient, worsened after canal surgery with an experienced surgeon. So it's my job, I guess, since I know about that and I know this child very well and it's impacted his life, you just need to know, and then you make your decisions. So I feel like I'm doing my part there. Failed ear reconstruction. This, and also true for failed MedPOR or porous implant reconstruction. And we all have, you know, failed, I guess, just means like not satisfactory to the patient and wanting to do something to improve. So this young lady had a, she was actually on our patient panel last year. And she's wonderful, but she was not satisfied with her results. There was hair growing on the ear. It was smaller. It didn't have good definition. So here she is after one surgery with a 3D PIER. And you can see it's a little hard to see too well, but it is definitely smaller. And here she is after one surgery. And just a close-up so you can see the comparison. So it's definitely harder to get a home run, so to speak, when somebody else has been there, because the anatomy is not as predictable. So we're going to talk quickly about the risks of ear reconstruction. Super important if you're sitting in there, but I highly recommend everybody watch. I have a 30-minute risks video. Like, we make every patient that gets a consult watch it, because that's how strongly I feel that you are educated and aware. So exposure, we've talked about. Infection, fracture, bleeding, meaning something happens after surgery, and like a true issue is you have to go back to surgery to deal with the bleeding. That's really rare. There is a nerve that makes your eyebrow go up. It does not affect going down, that we'll talk about. Removal of the implant, if the surgery just didn't work, again, super rare, but it can happen. And then vascular injury. So now this is my second and last pet peeve. When surgeons aren't transparent about the complications, and the complication rate is so specific. Again, we're taught in medical school, evidence-based medicine. So it is the number of patients who suffered a complication divided by the total number of surgeries you've performed. So that's consecutive cases. The only way that you can know that is to meticulously record everything you do in every patient, which I've been doing since the day I finished fellowship. So I'm going to tell you, these are 406 consecutive patients. These are only 3D ears, so I left behind the two-piece implants, but from January 1, 2019 to the end of 2024, this does exclude 240 patients where like they had a prior surgery. They're not part of this set. Anyways, clearly the most important is an exposure. I think I do as many of these as anybody in the world, and this is just accurate. Like, I wish it was lower, but I try. I try really hard. We don't always know why these occur, but as I showed with Wesley, like, as long as we can fix them, it's okay. That's the really hard part. This I'm super proud of. Fractures were 10% with that old two-piece implant, like a lot. Every fracture has to come back to surgery. Now, it could happen 10 years later, but like, if you could eliminate fracture, you've eliminated so many kids from having to have another operation. So when we started these 3Ds, it went down to 1.7%, which was great, but it isn't what I was after. So I changed the design because we had a few fractures in our 2019 set of kids. And once we made that first real design change, it dropped to less than 1%. So to me, like, that's an 85% drop from prior. It's crazy, makes me happy. All these other things are very, very, it is important that you can't say the complication risk of 3D implants is that, like, they're not specific to the actual surgery. They're actually specific to the surgeon. Everybody has complications. I think you all know that, but you need to have experience to be able to get patients over that hump. So this is the last section, what controls surgical outcomes? I tried to think of, what in my mind I can predict on, and these three kids have three totally different anatomic considerations for me in the OR. So I would say it's patient specific. Of course, it's technique specific. There's limitations to both of these two techniques that affect your results or your outcome. And then of course it's implant specific, because I believe these 3Ds really like up to the game for outcomes. But please beware, a lot of families want to know the future of medicine. When can we print ears, etc. And this company came out, and the surgeons that use this touted this as a 3D one-piece implant, but they're not all the same, because this company, Anatomics for Starpore, taken off the market. There was no explanation. They're now bankrupt. More than 95% of their patients needed to get their implants removed and replaced. So if you jump to this new latest thing, as you can imagine, you don't want your child to be like the guinea pig. You want years of data and actual peer-reviewed publication before you jump into that. Supor has been doing these ear implants since 2014, I think, with impeccable data. Also, I don't know if you remember when this came out, but 3D ear printed from a patient's own cells. And New York Times, doctors transplant human cell, ears made of human cells with a 3D printer. And this was the first early result, and they were all excited. And this was 30 days after. Again, they touted this as the look and feel of a natural ear. It shows this technology is not an if, but a when. However, citing proprietary concerns, the company has not disclosed the technical details. So like, nobody can evaluate if this is legit or not. The clinical trial was stopped, no explanation. You can't find it, scrubbed. And all the patients, or I shouldn't say all, because I truthfully only know some, but my belief is probably all needed to get their implants removed and replaced. So I guess the most important thing I want you guys to leave with is that your surgeon's experience, whomever you choose to go to, is really the thing that controls your outcome. And I feel like despite doing this exclusively, had a really big learning curve with these new implants. It's a lot more difficult than what I was doing before. I spent many years like inching my way towards getting to my first one-piece implant. I've now done these nearly 650 3D implants, which is many hundreds and hundreds more. I think maybe 30 or 40 would be the most anybody in the world has ever done. And even with that much experience, I'm still learning new tricks and developing new techniques. So I'll leave you with this little guy who I don't think I can do too much better than this. He's only 1 year after surgery. So of course, his ear will continue to improve over time. But on that score of surgeon experience being critical, please don't be shy to ask your surgeon questions. I mean, I know you're all here, so you're probably not the ones I need to preach to because you are going and seeing all these doctors, hopefully in other conferences that other surgeons help, but ask questions, demand complication rates with real meetings. Are these your complication rates? Or are you just sort of citing general complication rates? Please request photos from all angles so you, as a parent, know what you can expect. And of course, like doctor's website is going to have like, their like best example patients, but you can ask anybody on these Microtia patient groups, like reach out to them, direct message them and ask them, can I see pictures of your kid's ears? Confirm which implant will be used. I use Support exclusively. I really, really believe in them, but I don't know enough about the other ones to tell you much about that. So ultimately, you guys all know what's best for your own kiddo. Trust your gut. Why do I do this? So this was from 3 days ago. This is Matilda, goes by Tilly. And this is when she got to see her ear for the first time. 1, 2, look at your mom.
Oh my gosh. And you know it's swollen right now. That looks.
Do you want to hold this there so you can see?
Oh my.
Like, does it get any better than that, you guys? I mean, it's honestly like I'm blessed to have these kiddos, and every Tuesday I get a couple of these, and it really is really a wonderful moment. Okay, everybody, home run, watch. Owen. Look at this. Owen's on our patient panel. We got the legit athletes. Come on, all the way, buddy. There we go. Yay. Thank you, guys.